If your doctor just told you you tore your ACL, the first thing you should do is watch this video before making any decisions.
Before we get into it, for anyone watching for the first time, can you introduce yourself?
Sure. I'm Dr. Leon Popovitz. I'm an orthopedic surgeon, and I am a co-founder of New York Bone and Joint Specialists. I have been practicing for over 20 years, and I specialize primarily in shoulder and knee surgery as well as sports medicine. My philosophy is preservation is the key to longevity, meaning that we have to preserve your tissues at all costs so that you can have it for a long lifetime to come. Therefore, this surgical mentality allows you to consider all options instead of just surgery right away.
Can you explain what the ACL actually does in plain terms?
Of course. The ACL is a central ligament in the knee. So this is the knee, top bone, bottom bone, and in between are ligaments and cartilage. The ends of the bone are covered with a smooth layer of cartilage. It's on the ends of every bone, including the kneecap, patella. In between the two bones, you have a cushion of cartilage called the meniscus. It's on one side and on the other. Essentially, between the two bones, you have ligaments crossing each other. You have the ACL, the anterior cruciate ligament, in the front, and then the PCL, posterior cruciate ligament, in the back. The ACL provides stability. It provides stability, preventing the bone, the bottom bone, from shifting forward or from rotating.
What does rotational instability actually feel like to a patient?
So rotational instability is when the ACL, the ligament inside the knee, tears, and the knee does not have that sturdiness or stability when making any turns, and it feels as though the joint shifts and rotates. So for instance, if you're walking down the street and you need to make a sharp turn because a car is moving, you're going to turn to the left, for example. So the knee has to all move as a unit. But if there's no stability because the ACL is torn, the knee will start moving, but then the tibia will rotate like this, and that's rotational instability. It feels as though somebody's buckling or losing balance.
Is a partially torn ACL as serious as a completely torn one?
It can be. It depends on the stability and how much of the tissue is torn. So if this is the ACL right here, and more often than not, the ACL tears completely right in the mid-substance. And it's kind of like an explosion of the tissue. That's a complete tear. Sometimes you can have a partial tear where some of the fibers tear, but not all, and some hang on. The typical understanding is that if it's more than 50% of the fibers, the patient will have significant instability that they'll really suffer from and may potentially warrant surgery. But every patient is different. Some patients may have 20% of their ligament torn and they have significant instability. Some patients may have 50% of their ligament torn and have no instability. So partial tears are a little bit more subjective when it comes to the patient.
When a patient says, "I heard a pop and my knee gave out," what are you thinking?
Typically, a sports orthopedic surgeon, when they hear that, they think ACL tear. Very often, patients will come in with a history of playing, for example, soccer in Central Park or any park, of course, and they're running and then they're pivoting. It's a non-contact injury, and they pivot and they feel a pop in their knee and they fall to the ground. No one hit them, they didn't trip over anything particular. It's just that sharp, unbalanced turn creates that eccentric, that unbalanced torque on the ligament, and it tears and it creates that pop. What also typically happens is there's sudden swelling in the knee. Not everybody, but very often that is the case. That's the typical presentation. A non-contact pivoting injury, and that causes a pop or sudden swelling in the knee, and then inability to bear weight on that leg and having instability.
Does a pop always mean an ACL tear?
Not necessarily. Sometimes a pop could be the MCL, the outer ligament here. Less commonly on the LCL here, because it's a thinner ligament. A pop can really mean a lot of different things. Some people have kind of a snap, crackle pop in their joints as air pockets pass. So no, not necessarily every pop in the knee means an ACL is torn.
What do you find on the physical exam before you even look at the MRI?
Routinely, and the standard should be the patient, the doctor, the surgeon should evaluate the patient first before looking at the MRI. And sometimes, if out of efficiency, we may take a look at the MRI first, but really the standard is to evaluate the patient first. So we get a history, we find out how it happened and how the patient is feeling. Is the patient feeling unstable? Are they still swollen? And then we examine the patient. We look to see if the patient's able to fully straighten the knee. That's an important factor. Sometimes that inability to straighten the knee could be from a couple of reasons. It could be just from the swelling in of itself. Other reasons could be that the meniscus, the cushion of cartilage, may have torn along with it and has displaced and prevents the knee from straightening. Could be a loose chip that's floating around. Then we evaluate the level of swelling in the joint and look to see if there's any open injuries or anything of that sort. And then we evaluate the knee and we examine it. Some of the important tests we do is something called the Lockman test, where we take the knee and we hold the bottom part of the knee, the tibia, steady, and we shift the femoral bone. If the femoral bone easily shifts forward without any resistance, there's a high likelihood that's a ACL tear. That's called a positive Lockman. We could also do what's called an anterior drawer. We can hold the knee in a slightly bent position and pull forward on the tibia. And again, if it goes forward significantly without any resistance, that also gives us a sign that the ACL is torn.
What other injuries are you ruling out at the same time?
So really just about any intra-articular pathology or even extra-articular pathology could occur during an injury that had such a force that caused the ACL to tear. So sometimes the meniscus might tear along with it, and that's very, very common. Sometimes you might have a crack in the lining of the bone, which is the articular cartilage. That could be an osteochondral defect or a crack in the cartilage lining. Very often the patients have bone bruises because when the knee buckles so severely as a result, one bone hits the other bone, so there's bruising in the bone itself. Sometimes the cartilage lining above that bone bruising could be injured. Sometimes you may have ligament disruption on the outside of the knee, not just on the inside. The MCL, the medial, the inner portion of the knee has a very thick, large ligament that might tear, and sometimes the outer ligaments might be injured as well.
A lot of people assume a torn ACL automatically means surgery. Is that true?
No, that is not true. Any surgery, any elective surgery, is really a decision between the doctor, the surgeon, and the patient. Patients should be aware of all of the ramifications if they don't have surgery, and all the ramifications if they do have surgery. Most typically, the ideal candidate for an ACL reconstruction is someone who is very active and young and is involved in a lot of pivoting sports or heavy labor, or is having instability on a daily and regular basis, just walking the streets. And a lot of people do when they tear their ACLs. Some people might be a bit older and may not have a very active lifestyle. And those patients might very well do fine without surgical intervention. Those patients need to modify some of their activities if they choose to do so. Those patients may want to use a custom or off-the-shelf brace sometimes is fine for circumstances that might make them feel a little unsteady. But ultimately, it really is the patient's choice whether or not they want the surgery or not.
What does modifying your activity actually look like? Is it realistic?
Is it realistic? Yes. Yes, it is realistic. I see patients that when you explain to them that the pivoting, the jumping, the sharp turns would not be something that you could do, and the patient is a bit older, say, we don't give specific age categories because you could be 60 years old and running marathons and doing cartwheels all day and with no arthritic changes. But typically it's the age of the joint. So, if you already have beginnings of degenerative disease in your joint and you live a relatively sedentary life, you're not very active, and you try out the living with the knee for a couple of months, and say, and I typically do that. I say, why don't you try some physical therapy, regain some flexibility, and see how you do for a few months. And the patients come back and they say, well, I think, I'm not really that active. I don't really do any strenuous activities. I don't do any heavy labor. I can try to see if I can live with this. The reason why we're cautious about doing that with younger patients, say somebody in their 20s or teens or 30s or 40s, is that when the ACL tears, ultimately, if you don't fix it, the shifting continues, and that will eventually potentially tear the meniscus. And studies have shown that usually after 3 and 6 months, there is a higher likelihood of tearing your meniscus if you didn't already tear it during the actual initial injury of tearing your ACL. And when you tear your meniscus, there's a higher risk of developing arthritis because the meniscus is a shock absorber. It protects the articular cartilage that lines the bone. And if the articular cartilage that lines the bone flakes off because the meniscus is already torn and lost its function, and bare bone shows, and you can see the bare bone is rough and hard as compared to the articular cartilage, and that's painful, and that's arthritis.
Are there patients who surprise you by doing well without surgery?
Yes, sometimes. When you've seen so many cases, you probably don't get too surprised anymore. Yeah, there are patients that say, I don't want to have the surgery. I'm going to just watch it and see. And, they come back and they keep saying, I'm doing fine, I'm doing fine. Unfortunately, I'm always worried that they might tear their meniscus. If this was a younger active patient. If it's a sedentary patient that already has some arthritic changes, I usually brace them and offer them that option. And quite frankly, arthritis really is a contraindication for doing an ACL reconstruction.
Why can't someone just have surgery right away when it happens?
Well, it's a lot of different reasons, but first and foremost, you want to make sure you're as flexible as possible before going into surgery. So the more range of motion you have, the easier to regain your range of motion after the surgery. So the more range of motion you have before the surgery, the easier it'll be to regain your range of motion after the surgery. So a lot of times when the ACL tears, then it becomes very swollen, stiff, and painful. And we really recommend some preoperative physical therapy to regain that flexibility, get that swelling down. And then once that swelling is down and the range of motion is fully achieved, then it's much safer to proceed with surgery. Other reasons are when there's a lot of swelling, there's an increased risk of infection. So you want to get that swelling down as much as possible before going into the operating room.
What is cooling the knee down, and how long does it take?
Cooling the knee down is essentially getting the swelling down and getting it under control. And usually I offer about 2 to 3 weeks of physical therapy, of icing and rest before proceeding with the surgery. I do warn the patients that when you're cooling the knee down in the preoperative period before your surgery, that's really kind of a quote-unquote honeymoon period. You're going to feel much, much better. The swelling's going to come down. Your pain is going to come down, especially if you don't have a concomitant meniscus tear. And the temptation is to say, hey, I'm feeling pretty good. Let me go test it out. Please don't. Because if you go out there with an ACL tear after the swelling is down, you're going to go out there and your knee's going to buckle again if you pivot sharply. And then you're endangering other structures that have not been already torn to tear. Cool down is a rest period in preparation for the surgery.
What happens to patients who insist on surgery immediately?
Well, we're not machines. Just because a patient comes in and says, I absolutely want the surgery right now, that's not something we don't, at least I'm not. That's not something I would recommend any surgeon doing, just rushing to do surgery on someone that wants the surgery right away and already has their decision made. You want to make sure you have a thorough conversation with the patient, understand the patient. understand the needs of the patient, and most importantly, make sure that the patient understands his or her condition and circumstances. So that's first and foremost. As far as wanting to do the surgery right away and they're still very swollen and stiff, I would highly recommend not to. I would highly recommend doing the preoperative physical therapy at least for 2 or 3 weeks to regain range of motion before proceeding.
What happens to the knee if someone decides to live with a torn ACL and never has surgery?
So the typical sequence and the biggest concern is that there'll be more injuries and damage to the joint if you don't stabilize the knee by fixing or reconstructing the anterior cruciate ligament, the ACL. So if you don't reconstruct the ACL promptly, each and every month, there's an increased risk of tearing your ACL. I think it's approximately 10% risk each month you wait. So it accumulates. So the standard is that we really want to have. We typically recommend having the ACL surgery done between 3 and 6 months after the initial injury.
At what point does delay make things significantly worse?
Typically, after 6 months, we're concerned of causing further damage to the knee, particularly the meniscus tear. But even to go back to the last question, even if the meniscus does not tear, because of that constant instability in the joint, other injuries could occur. You can cause damage to the articular cartilage, or you can cause tears to other structures in the joint. Because the knee has to be always stable, it has to function as one unit. If you're walking down the street, you need to make a turn, you have to go this way. The joint has to move all as one unit. But if you're moving, if your body's telling you to move this way, and then the joint is moving this way, but the tibia is rotating, you're going to buckle and fall, and then the bones are going to bang against each other, and you're going to cause particular damage to what's most concerning is the articular cartilage. This cartilage is so important. It goes back to the concept of preservation. Preservation is the key to longevity. If we preserve this articular cartilage as long as possible, you will have a healthy knee as long as possible. And that holds true really for all parts of our body, all organs in our body. And it's a step-by-step process. So if our focus and goal is to make sure this articular cartilage is intact, this lining, this thin little carticular eggshell lining is intact, then we want to make sure the meniscus is intact, because the meniscus protects the articular cartilage. And then we want to make sure the ACL is intact, because the ACL provides stability, preventing the meniscus from tearing. So it's a step-by-step process, but the ultimate goal is to preserve the tissues in your joint. Sometimes, preservation of the joint may actually mean to do the surgery. So preservation, as far as the purpose in longevity, very often is to look at the full picture. Sometimes surgery is not absolutely necessary. Sometimes surgery is not absolutely needed, but sometimes we can preserve the joint without taking things out of the joint or resecting the portions that have been damaged. But sometimes, if we don't do a procedure to save an important structure or fix it or reconstruct it, then degeneration will develop, and then we're not preserving your joint, we're not preserving your structures. So preservation very often, and potentially more often, is not to operate and to preserve the structures, but particularly in sports medicine and athletic injuries, preservation very often is to actually do a procedure, do a surgery, to save critical structures in your joint.
Is there a patient population that truly does fine without surgery long term?
Typically, the older the patient is in combination with the less level of activity. So you can be older but very active and tear your ACL, have no arthritis, you need the surgery. I mean, I've operated on people in their 60s for ACL reconstructions if needed. They had no arthritis and they're very, very active, and that's perfect. We should all be that way. That's the goal for all of us. But unfortunately, some people already have developed arthritic changes and already live a sedentary life or a minimally active life. And for those people, it's really not necessary to potentially put them through a surgical procedure if it's not needed.
What does the first consultation at New York Bone and Joint Specialists look like for an ACL patient?
Well, it depends. If this is an acute injury and you have not been diagnosed as of yet, then an initial evaluation would be made, history as to what happened, physical exam to evaluate, to determine, and we determine differential diagnosis. We evaluate to see, because before doing an MRI, we don't have definitive objective confirmation that it's an ACL, but our physical exam and our history really gives us a good portion, some say 80% of the diagnosis. But of course, we always confirm with MRI. We do initial evaluation, we have a nice conversation as to what happened. We do a physical exam to determine what we think and what our differential diagnosis is, and we will most certainly get an X-ray. We do that right in the office. X-ray is for a couple of reasons. Number one, you had trauma, or you had an acute injury. You want to make sure there's no fractures. There's no acute fractures. If there's no acute fractures, that's actually very good, obviously. We also want to determine if there's any signs of arthritis. So that is not necessarily an acute help in determining management, but long-term it will be. So for example, if we subsequently get an MRI and we find damage on the MRI, the level of arthritis, ideally seen on the initial X-ray, will help to guide us as to where our decisions will go. We also look at the alignment, so we often will do a standing X-ray, because when you're laying down, there's no pressure on the joint, and we can't really see the alignment, real life alignment. So we will do a standing X-ray, and that will tell us, is the knee relatively straight or is it now angulated? If it's angulated, that usually is a sign of the beginnings or progression of osteoarthritis. So we'll do an X-ray, and then we'll most likely recommend a brace if there's instability, if it's an ACL injury, and icing, potentially some anti-inflammatory medicine to help you, or some over-the-counter anti-inflammatory medicine to help you. You always want to be careful with anti-inflammatory medicine. Make sure there's no contraindications. Make sure you don't want to take it with an empty stomach. And you will likely get an MRI ordered to determine objectively what's going on. We also do a diagnostic ultrasound in the office, which really these days is so advanced. We're able to see so much of the joint that studies have shown that the diagnostic ultrasound really are almost comparable to MRI as far as being able to make the diagnosis. So we do a diagnostic ultrasound in the office. We'll be able to really get a good idea in the office what the diagnosis is, but we still will order a diagnostic MRI to have an objective determination and have a detailed determination of what's going on in the joint. And we have a strong affiliation with Lennox Hill Radiology. We're able to get a concierge to get your MRI done very, very promptly, and they have facilities all over the tri-state area, so it'll be very convenient for you. You can get it done right next to your home or your place of work. And now, if you arrived in the practice to see one of the surgeons and you already have an MRI and you've already been told you have an ACL tear, then similarly we'll have a very good conversation. We'll understand what you went through, what you're going through now, what you're experiencing, what you're feeling, and we'll do a physical exam. We'll evaluate and go through the entire MRI, all the X-rays and the ultrasounds to get a definitive diagnosis and understanding. And then we'll have a conversation, a detailed conversation of what your options are. And together, we will make that determination of what your next step will be. What's the ideal treatment for you in particular?
What do you say to someone who expects surgery and you don't think they need it?
I say just that. You don't need it. I'm very blunt and open with patients. I get a lot of patients referred to me from other doctors that, and they tell me, well, they give me a call in advance sometimes, or they follow up afterwards and say, this guy really needs surgery. And it's very commonly, I will say, no, the patient really doesn't need surgery. We could probably get this taken care of and take care of this patient without the surgery. So I'm very open, but if I tell you the ideal treatment for you is surgery, then I'll be very open with you and I'll tell you why. And more often than not, patients are very astute. Patients understand their own body. Patients understand their needs. And patients understand what they're feeling at the moment with this injury. And honestly, the vast majority of the time, we come to a conclusion together.
What questions should every ACL patient ask their surgeon?
I think an important question to ask the surgeon, and shouldn't be shy to ask, is how many of these have you done? And what is your success rate? That's important because whatever surgery you do, whether it's ACL reconstruction, whatever surgery you're going on to have done, ACL reconstruction, rotator cuff repair, hernia surgery, any surgery, you want to be sure the surgeon has a good amount of experience doing the surgery and a good amount of success doing that surgery.
What is the wrong answer a patient should watch out for from a surgeon?
Well, yeah, I don't want to make any passivity judgments on any surgeon or what they might say. But I would be wary of someone that never allows you the option of non-surgical treatment, never doesn't even want to discuss the option of not doing surgery. That's probably something I would be wary of.
What is your philosophy when a patient comes in with a torn ACL?
So the torn ACL is a perfect example of, or microcosm of, the philosophy that I've ingrained in our institution, that preservation is the key to longevity. And again, so when the ACL tears, and it's been shown, that will lead, if not repair or reconstructed, that will potentially lead to meniscal tearing, which then could potentially lead to articular cartilage degradation, and that will lead to arthritis. So it's kind of a snowball effect. So that concept, more often than not, preservation is the key to longevity. Practically speaking, when people look at that concept or consider that concept, more often than not, it means no surgery. And often it does mean no surgery. But when it comes to ACL reconstructions in a young person who's active, has a long lifetime ahead of them, and God be willing, people in their 50s and 60s and 70s do as well, if you are active and if you do not have any significant arthritis, the conservative move, the move towards preservation, would actually be to fix that anterior cruciate ligament.
How does that philosophy change the conversation compared to a surgeon who defaults to surgery?
I think ultimately we may be recommending the same thing, but not always. And when you keep that concept in mind that you always want to preserve as opposed to rushing into surgery and just doing it for the sake of surgery, and then that surgeon's probably just constantly recommending surgery and not even considering the non-surgical options.
If someone just found out they tore their ACL, what's the most important thing to do in the next 48 hours?
I would probably start with this video. I would strongly consider everything that your doctor explained to you. Strongly consider your age and level of activity, what you want to do in the future, what your goals in the future is, and even postulate things you haven't postulated before. Maybe you want to take up skiing one day. Maybe you want to take up soccer one day. Maybe you want to go into the Navy. There are demands upon us that come up as life goes on that we often don't expect. And even if it's not physical, when you have to live with a physical ailment that can potentially get worse with time, it makes things very difficult. So to prepare yourself for a future with minimal ailments, and then that's why we want to preserve that tissue as best as we can for that future.
What are the mistakes people make in those first few days?
Well, I think one mistake could be to go out there and test it. I think some people might feel, well, it doesn't feel so bad. Maybe their swelling is not so bad. Their swelling comes down real quick. And when the swelling comes down pretty quick right after an acute ACL tear, you feel much improved. The contrast is dramatic. So you're like, I'm feeling a little bit better. Let me give it a test. And unfortunately, then you might cause more damage and further buckling and damage to your knee. So I would be wary of that. I'd be careful of that. If you just tore your ACL or you just found out you tore your ACL and you want to know all your options and you want to understand in detail what the ACL surgery would entail, and you need an appointment promptly without waiting for a long time, give us a call or click and we'll make sure we'll take very, very good care of you.